Hello, welcome to the session on understanding bias, microaggressions, and cultural humility to promote health equity. My name is Piri Ackerman-Barger. I am a nurse. I am a faculty member at University of California, Davis, Betty Irene Moore School of Nursing, where I serve as Associate Dean for Health Equity, Diversity, and Inclusion. I'm glad you're able to join me today. So to get our session started, I wanted to go over what health equity means so that we're working with a similar definition as we talk about how to get there. So health equity, according to Paula Braveman, is it's the opportunity for everyone to have a fair and just opportunity to be healthier. And so she says, this means that we remove obstacles to health, such as poverty, discrimination, and their consequences. And that includes powerlessness and a lack of access to good jobs with fair pay, quality education, housing, safe environments, and healthcare. And she talks about how it is striving for the highest possible standard of care for all people. And this means giving special attention to the needs of those at the greatest risk of poor health based on social conditions. And I think something that is really important is this notion of giving special attention to the needs of those at greatest risk. So this means that everybody isn't treated the same as you would think of under the term equality. Equality basically means that everybody is treated the same. Equity means that we are treating people based on need and circumstance. So it's a little bit nuanced, but if you haven't seen this picture before, it's a good description or good visual depiction of equality versus equity. So in the top, everyone has the exact same bicycle. And that might seem fair at first, but you can see that there are several people that bicycle doesn't work for them. So down below under an equity model, people are getting the bicycle or the wheels that they need to appropriately be able to get around. So similar with healthcare, not everybody needs the exact same thing. So one of the ways that we can get to this place of health equity is by having diversity. And so diversity has multiple approaches or levels of thinking. We can think of diversity in terms of social justice. When we talk about social, that means people. When we talk about justice, that means access to resources. And so this, again, is this notion that people should have fair and equitable access to the resources of a society or a community. In addition to that is the notion of cognitive diversity. And this means that when you bring groups of thinkers together that represent different backgrounds, different ideologies, different perspectives, different ways of thinking, that we have a greater capacity to innovate, to problem solve, to think outside of the box to solve some of the really complex healthcare issues that we have. And that is a huge benefit. That's what we need. We know that doing things the way that we've done them in the past have not moved us out of the health disparities that have been consistent historically and currently. So on this slide, I am showing you an article that was really interesting that showed that there was a scientific value for diversity. And they noted that diverse groups publish more frequently and are cited more often, and that diverse groups are better equipped to address healthcare disparities. So this really does make a good case for the why of diversity and how it helps us move toward health equity. So an important piece about this is to understand that diversity doesn't just necessarily happen via just bringing people together. In fact, when you bring people together that are different, there is the potential for conflict. And that's why the term diversity needs to be accompanied by the term inclusion. Inclusion is the process by which individuals view themselves as active members of a larger community, where their background, insights, and contributions are valued as part of the creativity and productivity of the group. inclusion then becomes the binding force for diversity, right? So some of the things that get in the way of us achieving our goal of getting to health equity and toward promoting inclusive learning environments, work environments, practice environments, and also contribute to health disparities is unconscious bias. So unconscious bias refers to those thoughts and beliefs that we hold that are outside of our awareness. Like we don't even really realize that these things are in play. And so I think it's interesting to note that the Institute of Medicine and their landmark report in 2003 about health inequities and health disparities, they said that bias, stereotyping, and prejudice on the part of healthcare providers may be a major contributing factor to health disparities. Here's another 2016 article by Elizabeth Chapman and her colleagues about physicians and implicit bias. And in this article, they say, physicians are not immune to implicit bias. Indeed, uncertainty and time pressures surrounding the diagnostic process may promote reliance on stereotypes for efficient decision-making. So a couple of important things I want to say is that for those of us that are nurses, there's almost like, oh, well, this is about physicians. We don't do that. And although it would be convenient for us to say that, that's not true. I would say that all of us are prone to this. This is sort of how our human brains work. So I would replace that term physicians with healthcare providers. And then the other thing is that there doesn't have to be intention to have bias. That's what the unconscious part is about. And this notion that when we are under pressure, when we are hurried, when we are responsible for making these high level decisions, our brain is trying to be productive and efficient. And one of the ways that we do that is through pattern recognition. And one of the ways that an example of pattern recognition is stereotyping. Right? We've seen this case before. We've seen a person like this before. And so it means this. And in those stereotypes, we make clinical judgment errors about people, what their motivations are, what's happening with them, what it means to be this person or to have this presentation. And that process contributes to health disparities and moves us away from health equity. So let's go into the slow brain process and the fast brain process as related to unconscious bias. So think about this in terms of the areas of your brain. So we know that in the prefrontal cortex, that the frontal lobe, this is where that higher reasoning, judgment, all of those decision making, that stuff is happening in your prefrontal cortex. And in basically the back of your brain, that's the fast brain. That's the limbic system. That's the amygdala. So we tend to think in our hubris, in our egos, that we are operating in the area of our prefrontal cortex most of the time. We think that we are being deliberate, rational, thoughtful, objective, and yet it takes almost 400 times more energy to be in this part of your brain. And so it takes effort and it's a slower process. And we are not in this place nearly as much as we think we are. The fast brain, this is effortless. This is where your brain goes when it's tired. This is going on, it says automatic. You might think about it as being on autopilot. You know, sometimes when you're driving, you go on autopilot. Sometimes you can go so much on autopilot that you actually miss your exit because you're just cruising down the road. This is also that pattern recognition. It's faster and it takes less energy. And let me just give you an analogy of this. I think about doing crunches. You know, when you're at the gym, you're doing your crunches, right? And I don't know about you, but usually when I get to about, 6 or 7 of a really good crunch, my stomach muscles start to get tired. And, I'm aware of it and I make sure I'm staying in my stomach. But if I don't pay attention, after a few more, I find that my crunches are actually coming from my back muscles and my back muscles are getting a little sore and cranky, but that's a different topic. But the interesting thing is I still appear to be doing sit-ups, yet I'm actually not working in my stomach muscles, I'm in my back muscles, and that happened almost automatically without my decision making in there. And I think of that with the brain too, that it kind of looks like you're doing objective clinical decision making, but actually you're tapping into your unconscious bias. So again, when you're tired, when your brain is fatigued, that's when we start going into those somewhat automatic processes. So let's talk about some of the health disparities that we see that that may be related to unconscious bias. So we know from the literature, there's pretty robust literature about disparities related to analgesia. So Black and Hispanic patients in the emergency department are less likely to receive analgesia than white patients. And this is not just true for adults, it's actually true for children as well that have presented with broken bones, appendicitis, abdominal pain. Black children and Hispanic children tend to be treated less often for pain than white children. So there's a judgment there. Native American men have the lowest life expectancy across gender and race groups, and that's something that we often are not aware of. I would like to do some more exploration about what is the cause of that, and what role does unconscious bias play in that. We also know, again, robust literature, that Black women are more likely to have poor maternal outcomes than white women, including higher risk of death, higher risk of a longer hospital stay, higher risk for having a C-section, and higher risk for severe morbidity, which would be things like eclampsia, shock, excessive bleeding, all of these things that can become life-threatening if not caught soon enough. And when we think about prioritization of care, when we think about which person are we going to see first, which person needs the resources of our department, we're making clinical decisions and we're prioritizing. And if in your subconscious, you have beliefs about the value of people, this may very well play out in those times when you're making priority decisions. And this doesn't mean that you're knowingly trying to violate your values and morals. You can be deeply moral. You can have high standards of care. And yet, because of the scripts about people that we've taken in passively without even knowing it, those can come to play during our decision making and have these sorts of clinical outcomes. So what can we do about unconscious bias? We need to develop the ability to self-reflect and self-critique. So this is that part where you recognize that you, like everybody else, are human, and that part of the process of being human is that we need to do our work around what things are residing inside of our unconscious. It doesn't mean that you're a good or bad person. We're far more complicated than that, but recognizing that the brain does some things and we do actually have the power to interrupt some of those processes if we're willing to take the time to look and see what resides in there. The other thing is the notion of being an ally and being anti-racist. And so what I mean by being an ally is that, I mean, a lot of times we can think about our group identities where we experience marginalization. But what are your group identities where you actually experience privilege and maybe in a more dominant group? And in those situations, how can you make sure that you are using your voice of privilege to help the other voices be heard, to help solve and to be active in recognizing some of the issues that are happening with groups that are different from your own? Let me just give you a personal example. I identify as a cisgendered woman. That means that the gender that I was assigned at birth is actually the gender that I feel. I was born a girl and I feel like a woman, right? I am straight and I am a married woman. And that is the expectation in our society. I'm not saying it should be the expectation, but it is the expectation. And in that, I have some privilege. So what can I do to truly be an ally to the LGBTQ plus community? And I want to be an ally in that I don't go and I say, hey, you should be doing this, and hey, you should be doing that. I'm going to come in and rescue you. But how can I help make sure that your voices are heard? What are the action steps that I can do to be fully supportive of the health and well-being of this community? The term anti-racist definitely is race specific. And so this means understanding groups that are racially or ethnically different than your own. And this means making action steps to be active in undoing the policies, the practices, undoing the beliefs and the culture that have supported racist outcomes over time. Another thing is about getting feedback and data. This is being open to feedback from people. A lot of times when somebody suggests that we might have prejudice or bias, our first inclination is to become defensive about it. And in that defensiveness, we stop listening. And in that stopping listening, we miss an opportunity to learn about somebody else's experience, right? Whether you intended something, maybe the two of you are having completely different experiences around an interaction. Whether that is true or not, this is a time for you to listen to the feedback that somebody has given you. And maybe it is that you learn more about the way that people have experienced marginalization and how you can be supportive of that person, even if your intention was not to offend or to create any harm. And then it's also an opportunity. There actually might be bias at play. And so I personally, when I get that kind of feedback, I stop for a moment and I spend some time thinking about what is the likelihood? Could it be true? And sometimes, yeah, it is true. I have taken in ideas and notions and taken them to be true. And I have to undo that and rewrite that script in my mind. I want to remind you that learning about other people's is deeply rewarding. It actually lights up the reward system in the brain. And the way I think about it is that we as humans enjoy stories, storytelling. We watch television where we're hearing and learning and experiencing, the lives of other people. That brings us a sense of connection and joy. And so I would encourage you that if this topic makes you feel uncomfortable, yes, there is the uncomfortable part of it, but there's also deep joy in getting to know and understand people that are different from you and connecting with you. And this is how we make teams. Some of my best memories about being a bedside nurse is when our interprofessional team was working well together, where we valued each other's roles. And there was this choreography that happens. And then there's like that debriefing that happens after, say, a code blue or something like that. And you just feel this connection with other people. And that to me was a joyful experience. And then the other thing is the notion of experiential reality. So I want to say that we are just as segregated in terms of social identities and communities. We're just as segregated as we've ever been. And this means that impedes our ability to connect with other people. When I think about my neighborhood, it's my neighbors that I'm connecting with. If I live in an all-white neighborhood, I'm going to be connecting with white folks. If I live in an all-black neighborhood, I'm going to be connecting with black folks. And that limits my understanding of groups different from my own and groups different from those in my immediate proximity. So that means that we have to be active and, number one, recognizing groups that we don't know very much about. And there's different ways to get that information by having authentic relationships with people that are different than us. And this goes beyond like saying hi to somebody at a checkout stand, or it goes beyond your patient interactions, but really truly a relationship where you're learning more about other people. And then the other way that you can do it is by reading books from people of communities that are different than yours, looking at the movies, the songs, the poetry, the artwork. All of these things are ways to learn more deeply about cultures that are different than your own. So I want to talk a little bit about the notion of microaggression. So microaggressions can be the output of unconscious bias. Um, so microaggressions are those things that are said, that are sometimes subtle, that are denigrating to people that are on the receiving end of it. Sometimes we are the source of a microaggression and we don't mean to be. And whether you meant to or not, the way that it lands on somebody else has impact. And sometimes we're the recipient of, and when you're the recipient of a microaggression, it leaves you thinking like, what did they mean by that? What was their intention behind that? How do I even respond to that? It can be really troubling. And here's the thing is that one microaggression over the course of a lifetime, or even a couple, we can recover from that. But there are people from certain identities that experience that every single day, to the point where people are actually like they're vigilant. They're waiting for, okay, when is it going to happen today? It's going to be at any point today, often at a moment where I don't have my guard up. So there's a sense that you have to constantly have your guard up. And for those of us that don't share the identity, we think, oh, that person's being oversensitive. Number one, there's no such thing as oversensitive. Your sensitivity is right sized to your experience and who you are. So yes, you may have some sensitivity, and the context behind it is I'm sensitive because I keep getting punched in this way, right? I'm worried about being punched because it happens to me every day. So what are some examples of healthcare microaggressions? Microaggressions said to a nurse, "You're so smart. Why didn't you become a doctor?" And as I've shared this example over time, I find people are like, oh yeah, I hate it when that happens. And I've heard other people say, yeah, I hear that all the time. It doesn't bother me at all. And so this doesn't mean that it's supposed to be a microaggression. If it doesn't bother you, great. But understand that there are other people that might be bothered by a statement like that, and their experience is real. Said to a Latino nursing student, this is actually a student that told me about this situation. He was doing well on the clinical floor, and somebody at the nurse's station told him, "You are a credit to your race." Seems like a compliment, but it's really not. Said to a student with they, their pronouns on their name tag, "Young people can't even make a decision about whether they are a boy or a girl these days." So I think of this as a double-barreled microaggression. It is an ageist microaggression, dismissing the experiences of young people. And then also it's a transphobic comment about the use of pronouns. So wow, way to be efficient in your microaggression. Take out a couple of groups at the same time. Yay. Said to a male nurse, "I didn't know that men could be so caring." This one is pretty rampant in nursing. And we need to be really cautious about this. And this, in terms of number and representation, women are in a privileged position in nursing. We have the power of numbers. There are some ways that men have advantages. Yes, there continues to be a pay equity issue. Men tend to get promoted. Those things are true. And it is true that men feel marginalized, particularly when statements like this are made. Said to a patient living with obesity, "If you only changed your lifestyle, this wouldn't be a problem." And for people living with obesity, or if you've worked with people that are living with obesity, or if you have the slightest bit of insight, you know that it's not that easy. There are far more complex reasons that people are living with obesity rather than it's just a lifestyle choice, right? And so that can feel like a microaggression to folks. Um, so going into a formal definition of microaggressions, racial microaggressions are subtle statements and behaviors that unconsciously communicate denigrating messages to people of color. And one of the most prolific scholars around this topic is Daryl Wing Sue, and he broke that up into several different categories. And I don't expect you to memorize these categories, nor do I expect you, when a microaggression is occurring, to try to figure out what kind of microaggression it is. But understanding the multiple ways that microaggressions can manifest gives you a sense of the depth and breadth of. So let me just go over some of those. Microassaults. Those are what we tend to think about when we think of a microaggression. Those are the intentional and explicitly derogatory verbal or nonverbal attacks. And remember that a good eye roll, that can definitely fall into the category of a microaggression. So ones that tend to be less intentional and are often unconscious are micro insults. So these are rude and insensitive subtle put downs of someone's racial heritage or identity. Another one is a micro-invalidation. So these are remarks that diminish, dismiss, or negate the realities and histories of people of color, saying that we're a post-racial society, saying that, you know, I don't see color. Yes, you see color. For sure you see color. Everybody sees it, even if you're physiologically colorblind. You know, saying that why do we keep needing to go back into history? Well, the fact of the matter is that our history is not gone. The threads of that, the legacy of our history remains today, and we are living with those circumstances. And so by saying those things, you're diminishing what people are experiencing, right? So we need to understand that microaggressions are not always consciously done. They're powerful because they are subtle and sometimes invisible, particularly to people that don't share that identity. And it's instances that cause the victim or the recipient to wonder in confusion, what just happened? What's going on here? There are many impacts of microaggressions. They cause mental health effects, and again, the literature is robust about the causal relationship, or the correlation, I should say, between microaggressions and anxiety and depression. And we know that there's a dose response relationship. So the more microaggressions one experiences, the higher the likelihood that they can manifest symptoms of anxiety and depression. They create physical health problems. And so this has to do with the notion of allostatic load. So allostatic load, there are several articles on it. If you don't know much about it, I highly recommend that you spend some time in the Google looking it up. Arlene Geronimus is a really important author on this topic. So allostatic load is the wear and tear, or the weathering of the body over time in response to stress. There are two primary biomarkers for allostatic load. One, the presence of hypertension, and two, the presence of stress hormones such as cortisol in the blood. And so I just want to take a moment to talk about stress and the role that it plays in our life. It is good. Stress keeps us safe. Stress keeps us motivated to get up and go to work and sometimes do the things that we don't want to do. Stress keeps us safe, and that we respond to situations quickly, sometimes automatically, before our prefrontal cortex is even engaged in it. And our body is designed for short periods of stress. And then what our bodies do is that we go into the parasympathetic response, where we are restoring homeostasis. In other words, our body has the time to recover and repair itself after a stress response. So think about, though, when you're in stress constantly, so there are not intervals of time to recover, or those intervals are so short that you didn't have adequate time to recover from those. That takes its toll on the body. It damages the body. So let's think about it from a physiological systems perspective. If you think about how your body responds to stress from the cardiovascular perspective, you have increased heart rate, you have increased contractility, so how hard the heart is beating, increased conductivity, so how quickly the electrical responses are happening in the body, and you have increased cardiac output that is helping the movement of blood throughout the body, the transport of oxygen, glucose, all of that. That's good during a stress response, right? We want that to happen so that we can have our flight, fight, or freeze responses. Your body also, at the level of the liver and the pancreas, makes more sugar available in the blood so that you have the glucose and the energy to deal with the stressful situation. Conversely, the GI tract and your metabolism take a back seat. That function is not prioritized during the stress response because you are in survival mode. Digesting your food, metabolizing your food is not a priority in this moment. Your immune system takes a back seat. Healing the, you know, the scrape that you got the other day is not the priority. Dealing with this, you know, potentially life-threatening, dangerous situation, that is your priority. And then the reproductive system obviously is going to take a back seat during a stress response. So all of that is fine and good in a temporary moment. Now, if this is happening constantly, if you're dealing with things, discrimination, racism, homophobia on the daily, that means that your body's in that stress response more often. It causes the weathering, the allostatic load. So let's go back to our systems. Over time, what does it look like? It looks like hypertension. Hypertension creates multiple processes, right? I mean, there's the high blood pressure part of it. There's cardiomegaly that can cause dysrhythmias. It creates thinning of your cardiovascular system, which makes you more prone to cardiovascular disease, etc. Right? So why are people from marginalized groups, why are people of color at higher risk for hypertension and cardiovascular disease? Stress, maybe stress. Then when there's sugar available in your blood, we have a name for that. When that's happening chronically, it's called diabetes. When your metabolic system and your digestive system are not working optimally, that can look like obesity over time. When your immune system is not working properly, that can look like autoimmune disorders, susceptibility to illness or chronic illness. And then when your reproductive system is having to take a back seat, this can look like poor maternal outcomes, mortalities and morbidities, low infant body weight, or higher increased mortality for infants, right? So all that allostatic load, that stress is not benign. It has mental and physical outcomes. And we see this played out when we look at health disparities. Why, again, do people of color have higher risk for all of these things? Why do people from marginalized group have higher risk for all of these things? It is very likely that it's a response to stress. So those are health outcomes. Microaggressions also, if they go uninterrupted, they can perpetuate stereotypes, and they also passively allow society to devalue groups. Every time somebody's made a racial joke and you haven't said something about it, people are like, it's okay to say that, right? It's socially acceptable to say that. It can cause lower work productivity. If you're spending time trying to figure out how to deal with a microaggression, that's taking time away from the task at hand and having to deal with a situation. And it also takes cognitive energy away, right? That's energy that is now in the limbic system because you're having an emotional response to something horrid that somebody said to you. So that's time not spent in the prefrontal cortex. They also create inequities in education, employment, and healthcare. One of the ways that we see it in healthcare is that if you experience a microaggression while you're in the clinic or working with a healthcare provider, it's going to make you not want to come back. Think about people living with obesity. Really, the lecture, if I just changed my lifestyle, everything would be peachy and okay. That's a microaggression. That's you invalidating my experience. And why would I opt to have that experience? I might start avoiding the healthcare system to protect myself from a microaggression. So I want to tell you a little bit about some research that I have conducted. This is an image of an article that came out in 2020. And so what we did is we conducted focus groups. And this is data from a sample size of 37 students from it was multi-institutional from University of California, Davis and Yale University, who identified as underrepresented in medicine or nursing. And I'm going to go through some of the results with you. So this was qualitative, and we themed the data using thematic analysis with some help from the in vivo software. And some of the themes that came up, one is the sense that students had of feeling devalued. So the first sub-theme is devalued and discounted. And so these boxes here are quotation boxes. So a student said, people would not respond to the things I'd say in the classroom, but they would respond to what a white person said, even if it was exactly the same thing. They would not acknowledge that I had contributed anything to the discussion. Another student said, there are times where everyone was asking, what did you get on this exam? And people would say, oh, I got an A or a B, or I got to retake it. And I didn't even want to mention it, but when I was specifically asked, I said I got 100% on this exam. And people would not believe it for some reason. Maybe because I'm Black? Another sub-theme was this teaching biological inferiority. So a student summed it up saying, yeah, that's one of the most challenging things, is to be in an institution that uses the word innovative in its language or leader in its language as far as mission, vision, and values, but they refuse to address historical and social context to health disparities. And being told by a professor that race is a biological fact in 2019 was deeply concerning to not only the quality of my education, but just like, I didn't know that eugenics was on the upswing. And I feel like, she names her school, is contributing to that. Another theme, the second theme, was looking at the impact of microaggressions. And so what I'm sharing with you here is the word frequency query that's available on NVivo, and they give you the option to make a word cloud. And the bigger the word, the more mentions it had. I included a lot of the mentions. I mean, some of these words were mentioned once or twice, but it gives you a sense of what the response is to a microaggression. So obviously anger, bad, doubt, frustration, but there's also other things that people said. They talked about saddening and heavy and replaying and draining. And, all of these are things that are going to take away from a student's ability to learn and to be present and to reach their full academic potential. So let's get into a little bit more of what students said about that process. So the sub-theme here is stress and anxiety. A student said, I've had to go on anxiety medications for depression because of the stress that we go through. I never had to do that before getting into, and they name their school. So I feel, I don't know if it's a consequence of the health profession school itself or the microaggressions. Another student said, you're performing and you're always stressed. How are you going to learn? Yeah, it's not the ideal way to learn. I'm a curious person. I enjoyed learning at one point, but when you're learning and you're feeling like you're already expected to fail, that's not a good feeling. Another sub-theme of the impact of microaggressions was divesting in discourse. And this is a powerful statement that one of the participants made. He said, yes, it has had an impact on me academically. In the past, if I'd had questions, I would have just raised my hand. I wouldn't have thought twice about it, and I would have sought out the answer. Now I think twice. In fact, every day before I go to school, I look at this thing I wrote for myself that says, please the teacher, melt into the metal, stay silent. I try to look at that and read that every day before I leave the house to remind myself to keep my head down and keep my mouth shut and not draw attention to myself. And one of the reasons that this is so powerful is that we go back to that notion of diversity and the value of diversity. This individual is now less likely to engage in the conversations that are happening in class, and we're missing then his voice and his perspective on whatever is happening, all these different learning experiences. We're not leveraging diversity if people feel like they can't speak and they have to put their head down and melt into the metal. Another sub-theme is the notion of diversity tax. So this is this feeling, this expectation that is put upon people of color to be the ones to solve our diversity problems. And this becomes an unpaid, unrecognized burden that many people feel like in order to make the lives of others better, that they're obligated to do this work. But again, it takes time away from studying and focusing on school. So one student said, the thought has come up a lot for me. What are all of the ways that students of color are being pulled away from their studies? Because we're the ones who respond whenever something happens. We'd show up. Another student says, I feel like I should have been a student and an advocate for myself when I should have just been focusing on studying. And I feel like that's been the hardest. I just want to study, but I don't have time to study because I'm going to all these meetings about things that are going on and things that are wrong and things that I want to change, organize for ourselves, that the school is not doing for us. So I'm not sure if I made clear when I introduced this study, these were all students who identified as underrepresented based on race and ethnicity. So these were African American, Black, Hispanic, Latino, Native American, Southeast Asian, and I hope I'm not forgetting anything. So yeah, they were underrepresented students. So in response to that study, as I've been disseminating that information, people have been saying this is compelling. What do we do? How do we interrupt this process? And so in response to that, my partner, Dr. Nicole Jacobs, and I wrote an article introducing the microaggressions triangle model. And I'm going to go ahead and share some of that with you. And so with the microaggressions triangle model, I want you to think about people as being on 3 different parts of that triangle, and think about you being on each end of that triangle, right? If you think about it, you can probably easily come up with times that you've been the recipient. I mean, that's what comes to mind for most people, a long litany of. But you've also been the source. You have absolutely been the source. I've been the source. You've been the source. We've all been the source, right? But it's harder to remember those times. And there's a couple of reasons why it's harder to remember those times. One, if it's the output of your unconscious bias, it may be that you didn't even recognize that you were the source of a microaggression. Two, if you do have some sense that you're the source of it, if it's uncomfortable enough for you, you might abscess that memory and abscess it until you're able to forget about it. I think about that movie Inside Out. I don't know if you remember, if you've seen that movie. There's a part where they are showing an analogy of memories going into this long lost land, and then they go away forever. Our brains will do that. So either that happens, or another process happens where you're trying to defend yourself and your self-identity, where you begin to rationalize why you said what you said or did what you did, and how, because if you didn't mean it or whatever, you're off the hook for it. Or even you might even go to a place where you start to feel like you're the victim because you were accused of doing something that you didn't intend to do. But remember that microaggressions are not about your intent. They're about the impact that it has on another person. Whether you intended it or not doesn't make a difference. I mean, it does make a difference if you're doing it intentionally. That kind of puts it into a different category. And I would say knock it off. But there are times when you legitimately didn't intend it, but it's still hurtful for somebody else. And we have the opportunity to recognize that and reconcile that. And then the other role is the role of the bystander. So this is those times when you weren't really directly involved, but you saw it happen, or you became involved because somebody has asked you to, mentor them or help them through a situation. So you're kind of involved by proxy. Sometimes when we see conflict happening, we don't want to get involved. We're like, I don't want to make it worse. I don't want to get involved in conflict. What does this have to do with me? And then you flee. And I want you to know that that's not neutral. You're making a strong statement when that happens. And from the perspective of the bystander, I know that you don't want to be involved in the situation, and neither does the recipient, but you are involved because of your proximity. You are involved because you were there, and therefore what you do after does matter. It's going to send a message to the different people that are involved in that. So back to that scenario that we used about, I mentioned it in the data. This is the individual that was talking about people discussing their exam questions. People said, I got an A or a B. They asked him what his grade was. He said, I had 100%, and people were surprised. And he was wondering if it's because he's Black. So let's just use that as the case scenario as we're going through some of the ways that we can approach this. So if you're the recipient, and please note that I am not saying that it's the responsibility of the recipient to deal with the situation. But it is sometimes the recipient can, and I get asked over and over from people who have been recipients, what should I do? So this might be a way to help think about potential ways to respond when you're the recipient. So this is the action approach. We didn't actually come up with this acronym. I think we have a citation for that. So the first one is ask a clarifying question. So in this situation, you might say something like, "You seem surprised that I received a high grade. Is that surprising to you?" And you can see what happens from there. Come from curiosity, not judgment. So you might say, "I want to better understand your surprise or what's happening in this moment. Can you help me understand what this conversation is about?" You might tell what you observed in a factual manner. For example, "I noticed that when you asked some of the other students about their grade, you did not express the same level of surprise." Impact exploration. This can be, "Ouch, your surprise makes me feel like people doubt my ability and my intellect." Or you might even go a little bit further with impact exploration, where you own your thoughts and feelings, and if you're comfortable, share them. So you might say, "It's difficult being the only Black student in our cohort. People often think I'm here to only fulfill a diversity goal. That's hard because I've always done well in school." So depending on how, like if you make some of these statements, depending on how the source is responding to you, then you can think about what next steps are. It may be, "Hey, let's go to class now, but if you want to talk a little bit more about this over coffee," or, something like that, there may be opportunity to stay in relationship with this person and learn and grow together. And it may be that they're responding poorly, and so you're just like, "Okay, I'm going to back out of this one," and use other channels to address that situation. Now, let's say that you realize that you have been the source of a microaggression. So this is the assist approach. And so within the assist approach, you acknowledge that you have bias, that you are like every other human, and you are prone to bias, right? And one of the best ways to avoid becoming the source of a microaggression is by familiarizing yourself with and mitigating your own unconscious bias. And that's something that you do privately, and that's something that you do often, and that's something that you open yourself up to a level of humility that allows you to do that kind of work. Seek feedback. So maybe you don't really understand what's happening, but you see that somebody looks hurt or is having an unexpected response to what you say. So you might say, "I noticed that when we were talking about the exam grades, you became quiet. How was that interaction for you?" So that gives the opportunity for you to get some feedback and gather some data. You can say that you're sorry. Apologies can be difficult, especially when we think of them as being an admission of intent or wrongdoing. But an apology shouldn't be about you, and what your intent was. It's really about recognizing somebody else's pain and the experience that they're having. So you can make a statement that acknowledges or focuses on the impact rather than the intent. And you might say that your intention was not to cause harm, but you want to make sure that you acknowledge the impact. So you might say something like, "Although it was not my intention to harm you, I see now how my questioning of your score affected you, and I'm really sorry." Right? And then also, if somebody has the courage and the strength to give you that feedback, to say, remember, the recipient might have said, "Ouch, that hurt," or, "It's hard being the only person of color in my cohort." They've given you a gift, right? They don't know how you're going to respond, but if they're saying something, that is an investment that they are making in your ability to learn and grow. They're having faith in you. That's actually a gift that somebody is giving you. And if they do that, the appropriate response for that would be, "Thank you." All right, the bystander. So for the bystander, we have the arise approach. So a bystander could have raised awareness of the situation by saying, "Your surprise about Rick's score suggests a biased assumption." So that's just laying it out there. That may not be my first approach in this situation, but it is an approach that you can take, is just putting the cards on the table and saying, "This is what seems like just happened in this moment." Responding with empathy and avoid judgment. And so it might be tempting to respond with negative emotions, especially if you're also triggered by that, or, you care deeply about the people in your classroom, the recipients, or the community. But avoiding judgment means allowing others the grace to make mistakes and learn from their mistakes. And it also means approaching the situation that two individuals may be having very different understandings or experiences in this. And with this particular scenario, a lot of people are like, well, of course, this is not a microaggression because, yeah, I would be surprised by anybody that got 100% on a nursing exam. Nursing exams are hard, so that's not a microaggression. And other people are saying it's clearly a microaggression because, why is this being said to this particular individual? So both of those things can be true at the same time. And one of the things that a bystander can do is to note those two truths that are happening at the same time and help the parties come to a place where they're recognizing, yeah, that wasn't my intention, but that's how it landed. Oh yeah, that was not their intention. They meant something else. And yeah, I'm going to own some of my feelings around that. So you might say things like, can you explain what you meant by that? It sounded like you were saying this. Is that what you meant to convey? A bystander can also use I statements. So you might say something like, I noticed that Rick seemed offended when you made that comment about his score. And you might say, and I was uncomfortable with it too, or I felt a little bit offended by it too, or I've been thinking about it, or any of those sorts of things that share with the source what your feelings were around it. And educate and engage. And you might say something like, I know you didn't intend to stereotype anyone, but as your friend, I want to let you know that what you said could be interpreted that way. Okay, so we're in the last section of the presentation. So I want to talk about cultural humility as a framework for promoting health equity. And we talked about humility. I mean, humility is an important part of coming to terms with your unconscious bias and the microaggressions that you might be putting out into the world. So cultural humility, this term was first seen in the literature in an article that was written by Melanie Turvalon and Jan Marie Garcia in 1998. It's a landmark article, and I highly recommend that if you haven't read it, that you take the time to read it. It's still very salient today. And let me give you just a little bit of background about it. They wrote this article in response to the notion of cultural competence. And so what I want to say is that in its original format, cultural competence essentially meant that we should be able to care for each other across cultural and identity groups, right? And that's a wonderful notion. You'll see Dr. Cross, I'm forgetting his first name at the moment, but he created the Cross model that talked about cultural competence. We have Dr. Campina Bacote also talked about cultural competence. Her model is amazing. But what happened over time, what we as academics tend to do is we try to turn everything into a metric. We want people to establish mastery or competency or have some sort of learning outcome that makes it seem like the work is finite, or that you can eventually say that you're competent or that you're a master of culture. And so what that has done is made us put the concept of cultural competence into this box that has become a stereotyping mechanism. So for example, on a nursing exam, you might see a question like, which of the following foods are part of African American cuisine? And number one, how is that helpful? And number two, as somebody who is mixed race and African American, I like all kinds of foods, and they may not be foods that other African American people like and consume and prepare. So it's highly generalizing and stereotyping, and that can be harmful, and that can be harmful in our decision making. So the four primary tenets of cultural humility are depicted here. The first one is lifelong learning. And this is this notion that we're never going to be there. This is a journey, and you will never have an endpoint where you have mastery over other people's culture and experiences. Um, it is this notion of redressing power imbalances, which means that we need to recognize those times that we have power. And it's complicated. You know, you can have power in one moment in one room and walk into a different room and be in a less powerful position. And there can be multiple layers of the power, but we do need to recognize that when we are nurses taking care of patients, we have a certain amount of power. We need to know this as nursing faculty, that in our faculty positions, we have power over students, right? And that can halt a conversation, that can halt disclosure, and that can impede the relationship piece that's necessary for us to be effective nurses and effective teachers. We also have to avoid the paternalism that we are prone to, thinking that we're all knowing and that we know what's better for other people, and that we're going to come in and rescue those who are less fortunate than ourselves. And that's condescending. That it's closely related to power. That's like this notion of seeing yourself as having power over other people, rather than recognizing the strengths of communities and individuals to be able to solve their own problems should they have the resources that they needed to do that. The next one is stewarding organizational level development and progress. I want to apologize for that typo. I've been looking at this for a long time and didn't even notice it. I have corrected in other realms, but I apologize that you have to see the word stewardizing. What is that even? So anyway, stewarding organization level development and progress means that we're basically upholding the previous three tenets, but at the organizational level. Organizations can engage in lifelong learning as an organization. This is how that institutional memory is important. We can redress the power imbalances that occur within our institutions. And we can also make sure that we as institutions, as a school of nursing or as a hospital, are not going to communities and saying, you have problems, this is what we're going to do for you. Rather say, you know, we have these funds, we have these resources. How can those resources be leveraged to help your community? So that concludes our session today. I'm hoping that you have a couple of takeaways from this, understanding what health equity is, and that some of the ways that we can get to health equity is through diversity inclusion. To get to diversity inclusion, we need to recognize unconscious bias. We need to mitigate the times that we're the source of microaggressions, and then also using cultural humility as a framework to move forward with health equity. Thank you so much for joining me for this session. I really appreciate your time and your attention. Bye-bye.